clinical pharmacy practice, the essentials of clinical pharmacy practice. And everybody in this forum can agree with me that is something all of us would be interested in. There is simple the Clinical Pharmacists Association of Nigeria designed this special series for us. It's all about skills. That's the only thing that will make us to be at par at the international level. To do justice to this series, to kickstart it, it's one of our own, in the person of Dr. Fumilayo Caroline Oluwabamimehin. We are pressed for time so that we'll finish in time. Everybody will go and sleep. Dr. Fumilayo, like I said, will be the presenter tonight. Her citation readers. She's a fellow, a multiple fellow of so many professional society. Among them are the West African Postgraduate College of Pharmacists, a fellow of the Pharmaceutical Society of Nigeria, a fellow of Nigeria Institute of Management. She's a member of the International Federation of Pharmacists. She has served her profession in so many areas. She retired as a director of head of department, FMC or Federal Medical Center. She belonged to so many professional bodies. Without wasting much time, could Dr. Fumilayo start sharing her slides?
Yeah. Thank you, sir.
Hello.
Good evening.
Yes.
Good evening, everybody. Evening. Can you see my slides?
Good evening.
Good evening, sir. Good
evening. Yes, clear.
Okay. I want to appreciate God for this opportunity, and I want to thank the ESCO and the members of the Education Committee of CPAN for giving me this opportunity. The topic is the essentials of clinical pharmacy practice 1, interpretation of laboratory investigations. And my name is Oluwatimileyin. The presentation outline is as shown. I'll be starting with introduction and going through so many things. This is the presentation outline. And then the introduction. I hope you are seeing my screen.
It's clear. Very
okay,
clear.
Sir. Okay. That laboratory investigations are medical procedures that analyze body fluids or tissues to aid in diagnosis, treatment planning, monitoring, and disease management. It involves analyzing blood, urine, and other samples. Clinical pharmacists are expected to be able to interpret these results and take appropriate decisions in patients' medication usage. This is because we want to ensure that we have safe and effective patient-centered care. Why are pharmacists interested in laboratory test results? Because we use it to monitor the drug therapies of patients to be sure that they are safe and they are effective. Like if you have a DM patient and you are requesting for a lab test to know how that patient is doing. We can also use it to detect adverse drug reactions. We can adjust dosages of medications in patients with renal impairments. We can also use it to assess the need for additional alternative drug therapy. Example, you can use the white blood cell counts after an antibiotics administration You want to know whether you want to continue with that particular antibiotics, if it's good, if it's sensitive, or you want to withdraw it and change if it's resistant. Then it's also an opportunity that creates teamwork among healthcare professionals in patient care. And last but not the least, it can be used to evaluate disease progression and or improvements in our patients. I must let us know that there are times we can have laboratory errors. And laboratory errors can be grouped into three: the pre-analytical, the analytical. It is important we prepare our patients who are going for laboratory tests. Like a patient who is going to do fasting blood sugar should be aware that it will be fasting overnight, at least 12 hours before that test is done. So it's important you give the necessary information. Then sample collection is equally important. The person filling the form should make sure that he's filling the correct information, the right name and the sex and all the other parameters. And it is important when they are collecting these samples, it should be collected in the appropriate bottles, because there are different bottles for different samples. At the analytical stage, if we have equipment malfunction or reagent issues, it can affect the results that will be given. Then at the post-analytical, when the result is being transcribed, it is important that it must be carefully done and the data properly interpreted. Because if these are not done, it will give an error and a false report. So it's important that pharmacists should be able to identify the inconsistencies and request for retest when necessary. What are the types of tests that we can have done in the lab? We call some of them the quantitative tests. These are tests with normal ranges. They will give us a range from this range to this range. So within that range, the patient is normal. Below that range, that is hypo. Above that range, that is hyper. Then another group of tests is those ones that will come with the qualitative, they call them qualitative tests. The results comes either as positive or as negative. Like maybe blood glucose is in urine, it can be positive, it can be negative. Then the third type of result that can come is the semi-quantitative results. And these ones comes in plus, either 1 plus or 2 plus or 3 plus. Like we have when you have a patient to ask a patient to do glucose in urine. It can be 1 plus, it can be 2 plus, or you have a patient you are requesting to find out to do test on malaria parasites. It can come as 1, it can come as 2, or it can come as 3. And these are used in when we are now doing the analysis. Now going to the test proper. Why are we interested? We'll be looking at urine analysis. Urine analysis provides basic information regarding the renal function, urinary tract infection, diabetes, or liver function. What is the normal color of our urine? It should be clear or pale yellow to deep gold. If we get any red color from our urine, then there is every sense of blood. If the urine is brownish yellow, then that is a sign of conjugated bilirubin in the urine. Other shades of red, of orange or brown can mean that the patient is on medications. So when we are asking our patients to go for tests, we should be able to know whether they are on some medication that can affect those tests. Then the pH usually should be between 4.5 to 9, basically around 6. If we have lower, then it's basic. If we have it higher, then it's alkaline. So there is something wrong. Then alkaline urine is a sign of alkalosis or bacterial infection, and it can be a sign of drug use. When we have proteinuria, that is protein in the urea, it is an indication of renal disease, bladder infection, of hypertension. When we have glucosuria, that is glucose in urine, that's an indication for diabetes mellitus. When we have ketonuria, that's a sign of ketones in the urine, and is a sign to let us know that that patient has uncontrolled diabetes mellitus. When we have hematuria, that is presence of red blood cells in the urine, That's an indication of trauma. It could be tumor or systemic bleeding, except of course for women during their menstruation. Then when we have bacteriuria, that's a sign of bacteria in the urine. It can be a sign of urinary tract infection. There are some medications that equally affect urinalysis results. And these are not limited. We have samples like riboflavin, metronidazole, levodopa, chloroquine, vitamin C. These affects, and therefore that is why we must let our patient know when we are asking or requesting them to go for blood for laboratory tests, to let us know the medications they are on so that they can be educated on this. Another test that we are looking at is the blood glucose test, and there is need to screen for blood glucose. We have the World Diabetes Day coming up in November, where some of us do free blood tests for patients, for clients to come. Some of them are not even aware that they are diabetes. It is when those tests are conducted that they get to know. And we have samples. We have different types of tests that we can do to determine whether we have glucose in the urine. We have the random blood sugar. That is a test that is taken at any time of the day. And you have values should be lower than 9.9 millimoles. For the fasting blood sugar, patients will not eat for a period of 12 hours, that is overnight. And that's why I said it is important that that patient should be educated. If you are coming for that test by 8 o'clock, which means the last meal must be 8 p.m. the night before, the patient must know. And the value should be between 2.8 to 5.5 millimoles. If it's less than that, then there's problem, hypoglycemia. If it's higher than that, that is hyperglycemia. Then the third test that one can use to confirm is the 2-hour postprandial. And patients, when they are going for this test, they would have been informed that they will carry their food along when they are going for the test. So they will do the fasting blood sugar first. Blood samples will be collected then. They will now go and eat and come back exactly 2 hours after the food, and another sample is collected. And then the results are now compared for the fasting and the 2 hours postprandial. Then we have the glucose tolerance test, and we can equally have the glycosylated hemoglobin test. That should be less than 7. So if by the time the patient or client goes through this test, a pharmacist can now identify that this is a DM patient or not, and we can know from the result that is being presented. The antibiotic sensitivity test is another important test that we need to know about. And the purpose of this test is to determine the most effective antibiotics to be prescribed for a patient with infection. In the laboratory, they have 2 methods. The disc diffusion method that can be used, and this is normally used in the hospital. Sometimes ago, the companies will come with the disc and the pharmacist will give to the lab. So these are the discs that they will use to do the analysis. Then for their students, they use the MIC method to teach their undergraduate students, which is the minimum inhibition concentration. The result comes out either as resistant or as sensitive. If it's resistant, then it means that antibiotic should not be used by the client. If the patient is already on that particular one, it will be withdrawn and another one will be introduced. And then the sensitive one can be with 1+, can be with 2+. If it's coming with 2+, then it will be better than using the one with 1+. This is to say that these are effective alternatives that can be prescribed. So there are times that we may have to change the antibiotics that patient is using. Another test that we'll be looking at is the lipid profile. This is a test used to measure the levels of different types of fats, lipids, in the blood. The test helps to assess the risks to heart disease and other cardiovascular problems. To conduct this test, blood samples are taken, and then the results, when they come out, you can do for total cholesterol, you can do for triglyceride, you can do for the low density lipids, that is the bad ones, and you can do for the high density lipids, that's the good one. The ranges are always specified on the forms, and this can vary from one hospital to the other. So the ranges that are given to us when our patients or clients is coming with the result, we look at these ranges on the form and we see whether it is hypo or hyper. And we know we use our statins for this. The next one, we'll be looking at the electrolytes. Electrolytes are essential minerals with an electric charge that play a crucial role in regulating various bodily functions, including the nerve, the muscle functions, the fluid balance, the body pH, and overall health. These minerals are required for building and maintaining strong bones and teeth, keeping muscles and the heart and brain working properly, and regulating body fluids. Deficiency in these electrolytes leads to administration sometimes of intravenous fluids, especially when you are bringing in a new patient into the hospital. They may want to start with intravenous fluids. They are broadly classified as macrominerals or or trace minerals. The electrolytes can be the chlorine, and the normal value for when the patient is coming with the result of the test, it will state for chlorine. If you are requesting for chlorine test, it will state the amount of that of chlorine that patient has, and it will be within the range. There is a range between 95 and 110 millimoles. As I said, the range will always be on the form. We can test for calcium, we can equally test for magnesium, we can test for sodium and for potassium and all the others. By the time the result is coming in, we will see the deficiency because it's within a range. The patient's result will be stated what amount. So it is either hypo or hyper. If it's less than the range, it's hypo. If it's higher than the range, it is hyper. And so if we need to correct, we can always know what to correct. Like if you want to deal with sodium, maybe a patient has sodium deficiency, you'll be thinking of giving sodium chloride, IV normal saline. And then for the same goes for all the others, depending on the deficiency on your request too. The deficiency is what you now try to correct with different drugs of choice. If it's for calcium, you want to give calcium supplements. If it's for potassium, you want to give magnesium supplements. Then we look at the liver function test. Liver function tests are a group of blood tests that give information on the status of the patient's liver. There are 5 tests, and these are liver enzymes. We all know that metabolism of drugs takes place in the liver, and the liver enzymes are actively involved. So we can do this: bilirubin, albumin, total protein, and then protein time. For patients with impaired liver, we are already talking of you may have to do dosage adjustments when you have to prescribe for them. And this is very important. As a pharmacist, you are in a medical we are in the world round team, or you've been able to get the results of a patient, and you can see that there is an issue with the liver enzymes. You may want to advise the prescribing physician to do dosage adjustment because the enzymes that are involved in the metabolism have been compromised. These are the liver enzymes. Sorry. The serum enzymes, we have the alkaline phosphates, we have the alanine aminotransferase, and aspartate aminotransferase. These serum enzymes are used to assist in the diagnosis of diseases such as cancer, liver dysfunction, and medical events such as myocardial infarction and congestive heart failure. Then the serum bilirubin is the breakdown product of hemoglobin of destroyed erythrocytes. That's our red blood cells, predominantly pigments in bile. The serum bilirubin is reported as either total bilirubin, and this can be conjugated or unconjugated. Direct bilirubin is equally the same as conjugated, and unconjugated bilirubin is not filtered by the glomerulus, whereas conjugated one is filtered by the glomerulus. Increase in serum bilirubin can be as a result of hemolysis or a liver dysfunction and bile duct obstruction. So it's important we monitor for hepatotoxicity of our drugs. And the most common things we see is that when we have issues like this is jaundice. And this is very visible when you see the yellowness in the eye of your patients. Then the serum albumin is a protein primarily really produced by the liver and found in the blood plasma. It plays a vital role in maintaining fluid balance and transporting molecules like hormones and vitamins and preventing fluid leakages from blood vessels. The normal range is between the 3.5 to 5.5. As I said, once the patient, assuming it is less than this range, then you'll be thinking of giving albumin. And if it's high, then we think of lowering it. Another one is still on us. We are still under the liver function test, the serum protein, total protein. Total protein is a measurement of the concentration of all the proteins in the blood. There are two classes of protein in the serum. We have the albumin and we have the globulin. Proteins are important components of all cells and tissues. High values can indicate inflammation from infections like HIV or hepatitis or cancer. So if you have a patient with low level of this, which means that you are suspecting any of this infection, and we can help that patient by the prescription of protein, which can be obtained, though they are very expensive. Then another test is the prothrombin time. The prothrombin time is prothrombin is a protein made in the liver. Prothrombin time is a blood test that measures the time it takes for the blood plasma to clot. It is one of the routine blood tests to evaluate the coagulation status of a patient. When we have patients that are bleeding and they are not clotting in time, then one will begin to look at this. And the wedding is very useful in determining the warfarin dosage, liver damage, and vitamin K status. The normal ranges is as stated. Then another group of tests that we are looking at is the renal function test. Renal function test is a group of blood and urine tests that assesses how well the kidneys are functioning. If there are issues with the kidney, we know the kidney is the excretory organ, then definitely we may have to adjust some of the doses of our medications. There are two tests under this. We have the blood urea nitrogen, the BUN, and the serum creatinine. The renal function decreases with age. In renal diseases, urea and creatinine accumulates in the blood because they are not excreted properly. The functionability of the kidney is vital because of drugs which are excreted through the kidney. So if we have drugs that are excreted through the kidney and your patient is on his and the kidney is already compromised, we'll be thinking of dosage adjustment as pharmacists. And this advice, as clinical pharmacists, you may want to advise the prescribing physician about this. And the reason, of course, is because of the results that you have access to, that you are looking at. Then the blood urea nitrogen is a medical test that measures the amount of urea nitrogen in a person's blood. Urea nitrogen is a waste product formed in the liver when the body breaks down protein. The kidney filters urea nitrogen from the blood and is excreted in the urine. So the BUN levels vary according to age and sex. So you may want to look at the age when you are looking at the results. The normal range should be between 8 and 25 mg per deciliter. Then the creatinine is a waste product too, generated from the muscle activity and protein breakdown that is normally filtered out of the blood by the kidneys and excreted through the glomerular filtration process in the urine. So creatinine levels in the blood are used to assess kidney function. Women often have a lower blood creatinine level than men because women have less muscle mass. You know, I've mentioned that the muscle mass is important, and because of the less muscle mass that women have, they will have lower values than that of men. So if you have your creatinine accumulated in the body, then there is a problem with the kidney. Hematological test. Blood is a specialized body fluid. It has four major components: the plasma, the red blood cells, the white blood cells, and the platelets. The blood that runs through the veins, arteries, and capillaries is called whole blood. This is a mixture of 55% plasma and 45% blood cells. Blood makes up about 7 to 8% of the normal body weight of human beings. The blood plasma is the liquid component of blood, making up about 50% of its volume. It appears as light, yellowish, or straw colored. It consists of water, about 92%. It serves as fluid that suspends blood cells and is crucial for transporting the proteins, the electrolytes, the nutrients, and waste products throughout the body. The red blood cells, these are the erythrocytes, are the most common type of blood cell, and they play a vital role in delivering oxygen to the body tissues. They contain hemoglobin, a protein that binds to oxygen in the lungs and delivers oxygen to the body tissues. And in exchange, carbon dioxide are taken and excreted from the body. Red blood cells formation takes place in the marrow, in the bone marrow. We have different values. The men has a higher value of 42 to 52%, while the women have 37 to 47%. If we have low PC value of this, that is a sign of anemia or blood loss or overhydration. And these are examples of red blood cells. The erythrocyte sedimentation rate measures the rate at which the red blood cell settles the uncoagulated blood over time, and it primarily reflects plasma composition. And this is the normal rates for the male and for the female. Normal ESR values increases with chronic infection, chronic necrosis, and established malignancy or myocardial infarction. You will get higher rates for this ESR. Then the white blood cells. White blood cells, also known as leukocytes, are part of the body immune system. They help the body fight infection and other diseases. They are produced in the bone marrow, they circulate in the bloodstream and lymphatic system. The different types of white blood cells are granulites, neutrophils, eosinophils, basophils, monocytes, and lymphocytes. And the normal range is between 5,500 to 11,000. If we have higher rates, is a sign of infection. And that is when you want to see what type of medication, what type of drug you want to use in treating that infection. Of course, you may want to suggest that the blood sample be taken if the patient is already on an antibiotics to find out whether it's actually very effective. And by the time the result is coming out, if he's saying it's resistant, then you want to change it. You want to give another one from the sensitive ones. And when you are giving antibiotics from the sensitive list that you've been given from the laboratory, you want to see how many pluses. If you have one with 2 pluses, that would be better than the one with 1 plus. This is an example of white blood cells. Increased white blood counts is a sign of infection, either bacterial infection, and it can equally be a sign of leukemia or tissue necrosis. Decreased white blood cell counts is a sign of leukopenia, which means that there is an issue with the bone marrow. The bone, I said the white blood cells are forming in the bone marrow. If we have bone marrow depression, then definitely there will be a decrease in the white blood cells. Lymphoma or toxic reaction or use of antineoplastic agents are equally signs of decreased white blood cell counts. Platelets or thrombocytes are small colorless disc-shaped cell fragments in the blood that play a crucial role in hemostasis. They are essential for forming blood clots and stop or prevent bleeding when a blood vessel is damaged. Platelet counts is obtained when a person does complete blood counts. And as I said, you will be given the normal range, and the value for the patient too will equally be indicated so that we know whether it is hypo or hyper. And this is an example sample. To conclude my presentation, laboratory investigations are very important in patient care, and pharmacists will definitely benefit from this. It improves disease management and patient care. The ability of clinical pharmacists or even pharmacists, you can be a pharmacist and somebody is coming with the lab result, believing that you are a member of the health team and that he wants you to interpret what has been said. We as pharmacists should be able to look through these results and be able to advise accordingly. Clinical pharmacists or other pharmacists need to be able to interpret the results of laboratory investigation, which is vital for optimizing drug therapy and enhancing pharmaceutical care services to our patients. It also ensures active and improved collaboration among all the healthcare providers, because whether you like it or not, you will have a relationship with those people that are sending in the results from the lab. You will have a relationship with the physicians because you may want to clear one or two things. You will have a relationship with the nurses because you want to adjust. Maybe you need an adjustment in the medication that is to be administered. You want to inform those nurses. So definitely it will improve our relationship among all the healthcare providers. And it is also an opportunity for pharmacists learning process. I'll be looking at two case studies briefly. We have patient A male RCA victim, was rushed to the A&E department. The following laboratory investigations were ordered: PCV, urine analysis, and blood glucose test. The urine analysis came with plus plus for glucose and equally for ketones. So you know that this patient is not only a diabetic patient, is untreated. The diabetes is untreated. Then the BP is coming at 80/60, which is a bit low. And you'll be thinking of course, they would have set up IV line for that patient. But because of this result now, you cannot give glucose, either 5% or 10% glucose. So you'll be opting for normal saline. Then the PCV is showing us 20%. Now this is an RCA. It can have an external bleeding or it can be an internal bleeding. If it's an internal bleeding with this low PCV, then you'll be thinking of surgery, and that patient is likely to be transfused. So you as a pharmacist have been able to order some of these things, and you are knowledgeable about it, and you can equally advise as well. The second case study is patient B, a 45-year-old man, was just brought into the A&E. He complained of high-grade fever for 1 week, has taken anti-malaria and paracetamol tablet, no positive results. Investigations ordered include blood tests for PCV, for white blood cell count, for reactinin, hello?
Yeah.
And liver function test.
Continue.
Okay. The PCV is showing 23%. The white blood cell is high. The PCV is low, so you'll be thinking of transfusion. The white blood cell is high, so you'll be thinking of giving antibiotics. The urea is high, the creatinine is high, and the liver function test is very high. One can start suspecting that this patient has taken anti-malaria, is not getting better. You may start thinking of Lassa fever. So these are areas that pharmacists too can come in and offer assistance in the health team. Then these are my references. Thank you very much. Hello?
Yes, I'm hearing you. I'm hearing you.
Yes, sir. I'm through.
Don't justice. Yes, okay. I've done justice to this topic.
Thank you.
Yes, I thank all the participants much. But for network glitches, I think it's a good presentation. Much time. We'll go into Q&A, question and answer. Please, if you want to ask any question, you can signify by raising your hand.
Thank you so much, Moderator Dr. Eugene, and the presenter that did wonderfully well. I am Dr. Solomon Kelechi Nwafuru speaking, the acting national chairman of CPAN.
Yes.
My boss is not around. He's quite little unfortunate that I came in a bit late. But based on the appraisal I have actually seen, I from here deduced that the presenter that is already retired from public service is not yet tired. So the information is actually flowing from the brain as it grows. As the number one CPAN in Nigeria
clinician.
today, I must tell you the truth that she retired, but she's not tired.
It's not tired.
The woman is not tired. She did wonderfully well. These are some of the things that the younger ones will not be able to put through. And she has actually done marvelously well for us to know the benchmarking in simulating the laboratory investigation in respect to medication adjustment and the recommendations to the health team. And that is a global thing. Just like we have the laboratory medicine, laboratory pharmacy, even in the Western world. It's even an area of specialty. I keep on saying it. Not that some people have taken it as a profession. We equally simulated in it. We cannot do without it. So based on this, I don't have much thing to begin to criticize about it. But the point is that there's an additional. And I know because of the want of time, anything about laboratory investigations are too broad. You cannot finish it even in a year, you begin to talk about it. Because these things are definitely divided into two. What we call the laboratory investigations and imaging investigations. Maybe in the next presentation, other people can come with the images. The imaging where we begin to talk about the ECG, begin to talk about the echocardiography, the colonoscopy, the endoscopy, the cystoscopy, the FNAC, fine needle aspiration cytology, and most of them, all those things are imaging. So it's a very wonderful one. I'm happy about this. So kudos, ma. The point about knowledge is that it cannot get finished. So, but I want to tell you the areas she has actually researched, she did well. That does not mean there is no need for additional. But at this particular juncture, she has done very well in this aspect of laboratory investigation she did. Maybe other things will act and thereabout. And as the national chairman, I will allow the room for other people to react and contribute. And the people should try to know that it shouldn't be the platform for vilification, to attack and thereabout. You just contribute as you can contribute and make it to run smoothly. So above all, thank you so much, ma. And congratulations for giving us this lucid information. And equally, thank you so much, the moderator, for actually the harmonization and starting on time for us to move forward. Thank you. And I remain.
Thank you, Dr. Solomon.
Active. Thank you.
Solomon, our Vice Chairman. You're welcome. Thank you. Yes, more contribution, question, and what have you. Signify by raising your hand, please.
My hands have been raised since.
Okay, go ahead. You are protected. Go ahead. Go ahead.
Thank you very much.
Yes.
Thank you very much to our presenter. It's not out of place if I say that Great Ife, she's an alumni of the University of Ife, and like we say, another Great Ife is a counterfeit. There's no other one like Great Ife. So well done, Dr. Oluwatimileyin.
Thank you.
My question is, I heard you talking about the pharmacist ordering for lab tests. So I want to find out, do you have practice settings in Nigeria where the pharmacist can order lab tests? And I'm talking within the hospital setting. Do we have such? And if we don't, how do we go about ordering lab tests to be able to either monitor the therapy or to be able to identify potential adverse drug reactions and all the various areas that you highlighted tonight? Thank you very much.
Okay. Thank you. Can I respond? Thank you, ma.
Yes.
In the hospital setting, we may not be able to do this, but in the community setting, yes, we do. If you're a community pharmacist, you order these people. The funniest thing is that they prefer to come to you. Even when you have very serious cases and you are saying they should go, they will say no, they prefer the pharmacy. So as a pharmacist in the community setting, you can order test. In fact, some of the laboratories around your setting will come and give you forms. And some of them even go ahead and give you incentives. That if you send patients to them, they will give you incentive for sending those patients. So in the community, as a community pharmacist, yes, we do. But in the hospital setting, for now, we cannot, unless you are going through the physician. Of course, if you have private patients, you can always ask them to go. You may have your own personal patients and you are requesting that they will do this test. You can see them in the laboratory. And I think that one is allowed. But if it's the hospital patient that is on the bed, the pharmacist cannot do that. So you can only do it for your private patient or in the community where you are the Lord and Master. But when we are doing that, I think the results should be actual. You can go through the results and then you discuss with other healthcare professionals.
Yes. More contributions, more questions. All round up. Hello. Hello. I only want to add that, broadly speaking, it's a tool. In pharmacy, we do both screening and diagnostic tests. Screening, well, the public health aspect. Then in diagnostic, in pharmaceutical care, well, when we want to identify health and drug therapy problem. So to apply these tools, pull off. I think I'm audible. Are you hearing me?
Yes, sir.
Hello? Yes. I said broadly, we use the lab tests for screening and diagnosis. It's a tool, basically. For screening, that's in occupation, it's applicable. Then the hospital section for diagnostic purpose in disease management, like chronic diseases, hypertension, diabetes, very applicable. For the screening, that's the public health aspect. For the diagnostic purposes, it's in pharmaceutical care when we want to identify health and drug-related problems to support what we are doing, because it's an objective evidence these days of evidence-based approach in our practice. Yes. 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 Somebody do we have any other thing to add? Or round up? I've not seen any hand raised. Not seen anybody.
Hello, can I talk?
Yes. Could Olabisi please answer his question? Answer, please. Sorry, ask. Olabisi, are you there?
Yeah, in the hospital setting, we may
Yes.
not be there yet. So we can write a form to request for a lab test. But if you're following up a patient on the ward or during ward run, you can initiate it by discussion. And if you go in and you feel that there's something that has not been done, you could actually discuss with the consultant and the doctor and say that, look, I think this one we should do this. Until we get there, if we cannot fold hands because we cannot initiate it, but we cannot write it or request for it, but we can actually initiate it, discuss with the medic, and get it done. I've had an experience that the doctor was okay, get the form, write my name, and send it. Do you understand? We have not gotten to a place that you can draw blood for patient or do physical examination, even in the hospital. We have a lot to do in the hospital setting, but we have to go there little by little by getting involved and making our professional presence felt, either during ward round or presentations. If you present such things like a grand round that we do in some hospitals, and you have this, they would actually listen to you. They would listen, but it doesn't come like that. You need to get involved, integrated into the ward round system, and you're having a rapport with the physicians. That's the way it runs in Nigeria. So I pray that the Lord will help us.
Yes. Yes. Thank you very much. Thank you. Okay. Thank you. I think in the absence, nobody is raising his or her hand. I cannot see. Okay. Could Elias says
okay, thank you
his
so much.
question, please?
Thank you so much. Marcela Soketreza is my name, and I'm from FMC in Egua.
Yes. Yeah,
okay,
thank you. Go ahead.
About the issue of dose adjustments, because most times when we have patients that have issue with their organs, for example, kidney failure or heart failure, those adjustments. How do we ensure our setting and the lack of facilities organs, particularly? Am I being heard?
Yes, yes.
Okay.
I'm hearing you.
Yes,
I'm talking
about people that have issue with their organs, particularly issue of kidney failure, which is very common these days. Every now and then, I have issue with their kidney issues, kidney failures. That most of them actually in the recent need adjustment of dose, but it's actually difficult to determine the accurate dose for those patients. So what do we think we should do to improve the patient in terms of adjusting the dose that will be optimal for the patient? Thank you. I also want to thank the presenter. It was actually a very wonderful presentation, coming from a retired but not tired, officer. Thank you so much.
Yes, very correct.
Thank you, sir.
Yeah, Dr.
Yes, sir. Thank you, sir. I mentioned that the results will be coming in. From the results that is coming in, we can know whether it is very bad, it is bad, or it's extremely bad. And that is actually what we can use in those adjustments. It's better we start low and then we can gradually increase. If, for example, the patient is supposed to take 50 milligram, and from the result that is coming in, and we see that the kidney is really very bad. From the result, when you look at the range, then we can start low. We can decide to go for 25 or 30. And then if need be, if the patient can tolerate it, then we can gradually increase that. We don't have the parameters here to measure the concentration in the patient's blood. In advanced countries where they have that, yes, it's easier. But in our own case, you just try and do adjustments based on the results with you. And when you are doing that adjustment, you carry along all the other healthcare professionals so that they know why we are doing that.
Okay, I thank you so much. But if it's something like antibiotics, we're talking about the issue of antibiotics stewardship.
Okay, sir.
When you start with the lower dose, could that be a problem for the patient in terms of developing resistance for that organism, for that particular antibiotics? Because when you start with the lower dose,
I will want to suggest if
you are actually not organism to the accurate dose for elimination.
Yes. Yes, if you are actually going for antibiotics, the best way to start is let the patient go for the antibiotics sensitivity test, so that whichever one you are picking for the sensitivity is one that has a high plus, maybe 2+, that you want to use to start. So if you are starting with one that adjusting the dose before the microorganism will get used to that, you would have been able to start. You will see for day 1, day 2, you should be able to see the difference. If it has actually been based on the sensitivity you picked from the lab.
Yes, even at that, I'm still concerned about the because when the dose is too low, even though it's sensitive to the organism is sensitive to the antibiotics, with a lower dose, it may still not be effective to eradicate the organism and may expose it to resistance.
In that case, will you want to suggest we may bring in 2 antibiotics? Because if you are adjusting the dose, it should not be too low too. That's why I said the result will actually determine how low your dose should be. If the result is very bad, then you may want to. If it's not so bad, you may not want to go halfway. You may want to go 75% of what the actual dose should have been.
Okay, thank you so much. I actually appreciate the contribution. I also want to say here that it's high time we also begin to look at how to do these tests. Because most of us think that these tests are, difficult to do. They should put urinalysis, for example, HIV screening, hepatitis B screening. These are simple tests that are based on antibody-antigen reaction that is very difficult, just like if one is doing as if one is doing a pregnancy test, just a simple test that one can determine, within 5 minutes. So I encourage you to get this and do some of these tests at the community level. Thank you so much.
Yes, sir. Thank you for that suggestion. Actually, at the community levels, you see pharmacies that actually carry out blood glucose tests. In fact, you even encourage some of your patients who can afford it to buy a glucometer, and then you teach them how to do it. It's a very simple test for the blood sugar test. And then for the BP, you can always use the BP machine. You encourage them to buy the BP monitor. Then for the pregnancy test, you already have a strip that can be used for pregnancy test. Now, so some of these things are something that we can actually do. Even for the urine analysis, there are times you can ask your patient, even if you don't have a bottle, get a stable place where the patient can urinate and come back after about 30 minutes. You see hands there. That's to confirm blood sugar. So if we as pharmacists, if we decide to show interest, like the first speaker said, that this is an area where pharmacists can even specialize in, we can actually come close to some of these lab scientists and get some trainings from them, at least for the simple ones that we are interested in. The complex one that need equipments and all that, we may not want to go for that. But for the simple ones, I think pharmacists should be able to do that. Because even those that are not health professionals, they will do their blood sugar at home. It's a very simple test.
Yes. I can see from Nuruddin Usman. Your hand is raised. Could you please ask your question? From Nuruddin, are you there? Hello? 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 Hello, fam. Nuruddin.
Am I on? Hello.
Yes. Could you please? Yes. Yes. Yeah.
Thank you very much. I just want to commend the presenter for this wonderful presentation. Am I being heard?
Yes, we can hear you.
We can hear you loud and clear. Go ahead.
So I just want to chip in on this matter of dosage adjustment, drug dosage adjustment. It's been a very fruitful discussion, but I want to remind us that drug dosage adjustment is usually dependent on estimated glomerular filtration rate of kidney, which is a marker of the function of the kidney. So there is no, it is not, it is usually standard. There are formulae, especially in this electronic age. You could have a formula of Cross and Gauss equation and some other equations that you can install on your phone, which thing has to do with drugs that are primarily made by the kidneys. First and foremost, the fact that somebody has a kidney transplant does adjusting dosage from people that have liver kidney transplants, unless if the kidney that has also been transplanted has also developed faults. So then that is a different question. But what I'm trying to say is once you use any of the required by an individual that has a declined renal function, in majority of official books, the MDX, the BNF, the Medscape official books, every drug realize that there are provisions for adjustments of goods in those books in particular based on the calculated EGFR. So it is a very simple process. And this is something any pharmacist can do. It depends on the setting. It depends on the type of hospital you find yourself. What you need to understand is to be confident, and whenever you observe anything, just hear it out, regardless of whether it is going to be used or it is not going to be used. It is by constantly bringing up issues with facts and evidence that one day that thing will be taken. In your own setting, it is not being used. In another setting, it is being used. So we must encourage ourselves to be proactive, not only in community health pharmacy, even in hospitals. It is because the pharmacy assume that it is never going to be accepted.
Yeah, thank you.
What
I can see.
To bring up these issues, I assure you one day something will happen, and it might lead to the initiation of the implementation of that. Thank you very much.
Thank you, sir.
Thank you. Thank you. Thank you. Thank you, from Nuruddin. I saw Dr. Ifoma. Dr. Ifoma, you raised your hand. Yeah.
Yes, sir. Good evening.
Question.
Good evening, sir. I'm pharmacist Ifoma. So I want to, just add a little to what the last speaker said. I appreciate him for clarifying that of, those adjustments, the use of calculating that it depends on glomerular filtration rate. That's the formula and all that we use to, from what the result gives us, from what that result gives us, we'll be able to do some dose adjustments as needed. So what I just wanted to add, not to clarify, there was the person that asked about, that was so concerned about subtherapeutic dose. Won't there be introduction of resistance and all that? So I think what Madam is trying to say, from what the last speaker said, let's remember that we are talking about the liver that is meant for metabolism, or the kidney that is meant for excretion, malfunctioning. Okay, let's talk about the kidney. It's malfunctioning. So if it's malfunctioning, it means that it's not able to excrete as much as it should. So if you adjust the dose, okay, for somebody that has normal kidney and is supposed to take something like 50 milligrams, but this person that does not have normal kidney, from your calculation, they need to adjust that dose and give the person 25 milligrams or 20 milligrams or 30 as the case may be. There shouldn't be issue of resistance. You can't call that subtherapeutic dose because the kidney itself is not functioning well. If nothing is done, it's going to retain more than it should. I think that's what Madam was trying to explain there. So there's no fear. There shouldn't be fear of that there will be resistance, because this kidney is having issues and you need to adjust that dose so that it will not be too much in the body. So if you bring it down to a certain a better level for the body, the bacteria is not going to become resistant to it. It will still be susceptible to it. I hope I was able to clarify a little. And I want to appreciate the presenter. She really did wonderfully well. Thank you very much.
Thank you.
Okay, thank you so much. I was going to ask that question because we are talking about the bacterial load, and the because the bacteria is not located. It's not as if it's localized only in the kidney, you know, and the rate of metabolism or the rate of excretion, you know, is not actually accurately determined. You know, you are just doing a guesswork. And what I'm trying to say is that you might end of the day bring the dose to a level. Hello.
Yes, I'm listening. I believe we are all listening.
What I'm trying to say is that you might end of the day bring the dose to a level that is sub-therapeutic. You know, because you, particularly when the patient has issue with a very deteriorated kidney function. Let's say, for example, in stage 3B of the kidney disease, you know, and you say you want to reduce the dose to very, very low level. What I'm trying to say is that low level, because we didn't determine the accurate dose, the optimal dose for that patient, then we may end up having a dose that is low to the extent that it can now, you know, go into the issue of a drug resistance. That's what I was trying to put across. Thank you.
Okay, sir.
Hello.
Thank you. Hello, I'm hearing you.
Okay, I know that the previous speaker
I can see Professor Ronald Joda and Professor J. You are welcome. You are welcome. These are leaders in the academia. You are welcome. I can see Wing Commander Michael. You are welcome too. Dr. Kwatoyin, ask your question.
Yes.
Yes. We'll soon round up.
So I was just trying to say that just to bring a little bit more clarity. So when we talk about those adjustments in kidney disease or liver disease, the focus should not be on just the adjustments. We should talk. We should consider the bioavailability for the product, and then the concentration, the amount that is going to be circulating in the blood or in the system, and that is what is going to be increased, because when there is a reduced kidney function, then the amount excreted is going to be reduced. So we're still going to have so the issue of suboptimal level of availability in the body is not going to arise. So we need to focus, take our focus from the dose. We are talking about the amount, concentration of the medication that is available for activity in the body, and that is already going to be increased because there is limited kidney function. So you're going to have increased concentration instead of having, you know, because the excretion, for example, and metabolism is going to be reduced. So you're going to have increased concentration. So the issue of subtherapeutic dose does not come in. It's not dose that we should focus on. We should focus on the amount available for activity in the body. So it's not going to be subtherapeutic. And then like one of our colleagues had already shared on the chat platform, this dosage adjustment came up, the specified doses for different drugs are listed in formularies or in reference books like the BNF, and it came up as a result of scientific activity and calculation. So they didn't just do it out of the blue. So all of the concerns that we have about subtherapeutic doses were considered in those calculations and in those references that we have. So there is nothing to worry about subtherapeutic dose. I just wanted to bring that on a little bit more. Thank you.
I think that is very correct. Maybe let me add
We're
this
rounding
a
up.
little. The idea of the adjustment in antibiotics, usually the first dose is given in a normal dose, that's the loading dose. Because if, for example, you are taking 500 milligram ampiclos every 6 hours and there's declined kidney function, over the next 6 hours when the next dose is going to be taken, that 500 milligram will continue to be in your blood. Probably very little will have been excreted. So by the time you take another 500 milligram, then you're going to have too much in the plasma. That is the essence of the adjustment. So that is why the first dose is normally normal. Subsequently, you now begin to reduce the dose so that your plasma concentration will be normal. I think that is another area, another explanation that will add to the previous explanation. Thank you.
Thank you. All right. The last question. Mama Abedi, have you asked your question? Are you okay with the answer? Mama Abedi?
No. Yeah. Good evening, everybody. I want to thank the.
Hello?
Yes.
Fine.
Can you hear me?
Go ahead. We're rounding up.
We can hear you.
Okay, beautiful.
Yes.
I want to thank the presenter and those who have contributed to this question on antibiotic dose adjustments. I want us to also understand that the tests that are done should be done on a continuous basis as you treat your patient.
Yeah.
For a patient that has an impaired renal function, even with your those adjustments, you will also continue doing your kidney function test.
Yes.
To see if your medication, your dosing is actually making the kidney worse, or if the kidney is still maintaining its function at the level it is. For antibiotics also, you continue doing your full blood count to check the level of the white blood cells. If the white blood cell count is elevated and it's not coming down, it means the antibiotics you're using is not working. So it's either the dose is too low or you need to change the antibiotic you're using. I believe that's one of the essence of this, the topic that we took to.
Yes.
We shouldn't just look at one direction. There are so many tests that can be done to help us come up with the best result for our patients. We have to look at the risk benefits of whatever medication we are using. If we say we want to clear the microorganisms, and at the end of the day, we are damaging the kidney or one of the organs, then we are causing more harm than good. Thank you very much for giving me this time.
Thank you. I'm very happy with the turnout. It's quite impressive. We'll be rounding up, except if you have objection. But I think everybody is happy. Without wasting much time, this pharmacy said, "No, the around. Do please lead us in a Muslim prayer." From Abubakar, Abdul Karim. Hello. Hello. Is Mama back around?
Can we pray?
I saw Manolina.
Can I lead a prayer?
Yes, go ahead, go ahead.
Okay. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين اللهم صل محمد وعلى آله وسلم صلى الله عليه وسلم الحمد لله رب العالمين. May Allah sanctify the lectures into our hearts that should be able to implement it wherever we go, in the hospitals, in the clinics. Amen.
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 Thank you so much. Thank you.
Body.
Bye-bye, everybody.
Thank you. Thank you all. Bye.
Thank you.
Thank you.
Bye-bye.
You're welcome.
Pharmacist Eugene. Yeah.
Yes.
Thank you, Dr. Bello.
Yes.
Thank you very much.
Yes. Thank you. Thank you, Dr. Ipoma and Oluma and Fumilayo.